Welcome to the Society of Surgical Oncology 2017 Breast Fellows Webinar Number 2, Hereditary Syndromes. The moderators for today's program are Drs. Gretchen Arendt and Susan K. Bulbul, the invited discussant, Darcy Thull, and the case presentations will be conducted by Dr. Zeynep Bostansi, Sasa Spino, and Lerna Oskin. Audiocast quality is subject to your equipment, available bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option provided in your confirmation and reminder emails. If you have called in, operator assistance is available by pressing #. We encourage all participants to call in using the phone number and passcode in your webinar email so you can actively participate in the discussion. Those who call can signal that they would like to speak by pressing #, on their telephone keypad, and your line will be unmuted. You may also send questions at any time by using the Q&A window located on the lower left corner of the presentation screen directly below the chat window. Just type your question at the very bottom of the Q&A box and press Ask to send it. A brief question and answer session will follow each presentation. I'm going to turn the call over to Dr. Arendt. Please begin.
Okay, well, good evening, everyone, and I also want to extend a welcome to the second Breast Fellowship webinar for 2017. I am currently at the University of Colorado, and I will be moderating tonight's session along with Susan Bulbul, who is the Chief of Breast Surgery at Beth Israel Medical Center. And as you've heard, also joining us tonight is Darcy Thull. Darcy is a licensed certified genetic counselor who specializes in cancer risk assessment and genetic testing for hereditary cancer predisposition. She completed her master's degree at the University of Pittsburgh Graduate School of Public Health, and she's been part of the UPMC Cancer Genetic Program since 2001. So we're delighted to have her joining us this evening. The objective of the fellowship webinar this evening is to foster discussion among the program trainees, especially when talking about complicated cases or if there's controversy or variations in management. And tonight's program will cover 3 cases associated with hereditary breast cancer. Specifically, we'll discuss the evaluation, counseling, and management of an unaffected patient with a mutation, a patient who has a documented mutation and a new diagnosis of cancer, and a patient with a mutation in a non-BRCA gene. And specific points to highlight tonight include appropriate screening recommendations, options for prevention and risk reduction, cancer treatment recommendations that are specific to this high-risk population. And then further, with the widespread use of gene panel testing, we'd like to review the selection of appropriate testing for an individual. So without delaying any further, the first case will be presented by Dr. Zeynep Bostansi at City of Hope. So Dr. Bostansi?
So I'll be presenting an unaffected woman with significant family history of breast cancer. Is a 25-year-old asymptomatic woman with significant family history of breast cancers and an ovarian cancer. She otherwise does not have any significant past medical history. Her mother, who was diagnosed at age 34, and she also has a sister who was diagnosed at age 26. Both had genetic testing, and it was uninformative. Other risk factors include menarche at age 12. She did use oral contraceptives for 5 years previously. She's currently having regular menstrual periods. On physical examination, her skin and nipple and areola of the bilateral breasts are normal. She had very dense and nodular breasts bilaterally. However, there were no dominant masses, and there was no lymph. Prior to seeing us, she did undergo a bilateral ultrasound in January of 2017. This was prompted by her sister's diagnosis of breast cancer. On this ultrasound, she was found to have a simple cyst that measured 5 by 4 by 3 millimeters at the right breast 6 o'clock, 1 centimeter from the nipple. After evaluating her, we did get a follow-up of this ultrasound of the right breast, and the cyst was no longer visualized. And we are planning on getting an MRI. However, we couldn't do it after we saw her because she had to return for her school. Going back to her family history, as I mentioned, she does have an extensive family history. You can see her marked here, age 25. Her sister was diagnosed at age 26 with breast cancer, and her mother who was diagnosed with breast cancer at age 34. Both had broad panel genetic testing, and I should mention that they're from 2 different companies, so slight variation in those tests, and both were negative. She also has a grandmother who was diagnosed with breast cancer at age 65, and a great aunt who was diagnosed with ovarian cancer at age 65. 2 third-degree relatives, cousins who were diagnosed with breast cancer at young ages, and these were tested and also found to be negative. There is no consanguinity in the family. They are coming from Russia and Iran. So because of the uninformative genetic testing of our patient's sister and her mother, no genetic testing was not recommended. 2 models to estimate her breast cancer risk. One of them is a cloth model. This is a screenshot from an app. The app's name is called B-Risk, which is created by City of Hope. It takes into the patient's age into consideration, as well as up to 2 family members with breast or ovarian cancers. The cloth model calculated her risk to be 45% by age 79. Thyrocusic model takes both her personal history and her family history into consideration. So we entered things like menarche, whether she was BRCA1 and 2 tested, and she was had, and then we were able to enter her mom, her sister, and her grandmother into this model. And in the thyrocusic model, can actually indicate whether these relatives are previously tested for BRCA1 and whether the result was negative or positive. So the result of the thyrocusic model is the lifetime risk of 33%, which would have been higher if we did not know the genetic status of her relative. So according to the NCCN guidelines, she did meet testing criteria, having close relatives. However, in this case, genetic testing was not recommended because she's unaffected and 2 relatives are uninformed.
Please continue to speak clearly into your phone. Several people say you're fading in and out.
Okay, sorry about that. So
thank you.
So I was saying that BRCA testing was indicated in her case. However, it wasn't performed because of the uninformative testing of her relatives and because she is unaffected. So we came up with a plan taking into consideration her family history as well as personal factors, which is basically her age and her being in school. So we will be seeing her back once she's done with the school in August and perform a breast MRI at that point. She indicated that she is interested in undergoing bilateral risk-reducing mastectomies. We did counsel her about high-risk screening with MRI and ultrasound and potential mammography now or after 30 years old. However, given that her sister was just diagnosed with breast cancer at 26, she is she's inclined towards bilateral mastectomies. So we will have her see plastic surgery when she comes back, and then we'll repeat the screening in February 2018 with a breast ultrasound and a mammography, recognizing that this might be low yield given the dense breast. and then we will repeat an MRI 6 months later from that, which will be pre-op from her bilateral nipple-sparing prophylactic mastectomy with immediate reconstruction in the summer of 2018. So this slide shows several breast cancer risk models. The mutation probability models, in this case, will sort of not look at those because we know that she already has genetic testing and it was negative. The bottom part of this table shows the other risk estimation models. Here we use the Tyrer-Cuzick model, which takes several family members into consideration. The third-degree relatives can only be cousins, so therefore the great-aunt could not be entered with ovarian cancer into this model. The Gale model, in her case, would not apply because she is younger than 35 years old, and her risk is mostly driven by her family history rather than the personal factors. I did do a Bodicea risk estimation as well, which estimated her risk to be 35%, although that model is more applicable to European and French-Canadian descent. And then BRCA Pro model, again, could not be used because she's already tested negative for BRCA1 and 2.
Well, I thought she did not have testing.
Correct. I apologize for the relatives got tested. Concludes my presentation.
Okay, thank you for that comprehensive overview of the different risk assessment models. I think it's very important to understand when models are applicable and when they're not. And as you stated, Gale model would really not be an appropriate model to use in estimating this patient's risk. I do want to ask Darcy for some input on whether she agrees with not recommending genetic testing for this unaffected individual.
So I think
please mute your phone if you're not speaking so we can avoid the feedback.
So with regard to not testing the patient, I think that as long as her family members had an extensive panel, which include genes for both breast and ovarian cancer, that you would be extremely unlikely to identify anything different, particularly since you've tested both her mother and her sister and reportedly have tested those first cousins once removed.
Darcy, this is Susan Boble. When you say extensive panel, because right now in 2017 there are so many panels out there, can you clarify what that really means?
Sure. So I think
Hello?
Hi, sorry.
Yes?
That's okay.
With regard
what I mean
to
by that is it a breast-only panel? Is it looking at other genes? Is it looking at only high penetrance, or does it include low penetrance genes?
Sure. Excellent question. I think that with regard to the panel that I particularly would choose would be a panel that is directed toward breast and ovary cancer. And so those panels, most of the time at the clinical laboratories, have somewhere about 20 to 21 genes on them. Those genes are broken down into 3 categories: high-risk genes, which would include genes like the BRCA genes, P53, the Lynch-related genes, and those genes would capture the predominant risks for breast and ovary cancer. They would also have moderate risk genes inclusive of the sort of moderate penetrance breast cancer genes, and those would be ATM, HALB2, CHEK2. But in that category would also be some of the newer ovary cancer genes, and so that would be captured. And then, of course, most of these panels, if we want to look at a broader set of genes, have the newer genes that are on them. And so those are genes that I think at this point have less
clinical utility, since we really don't know what the cancer risks are or the spectrum of disease, and by no means do we have any sort of medical management guidelines. So if we find a mutation in one of those newer genes, at this point we're really relegated to managing that individual based on family history alone. So I don't think I would do a 100-gene panel, because I think that the usefulness of that in this situation would be low, and that you would just be opening up yourself to a higher chance to get variants of uncertain significance, which really don't provide any helpful clinical information at this point in time. And so I agree that clinical genetic testing for your patient would unlikely to be helpful. I would, however, like I'm sure that the physician did, want to see the actual gene panels from her family members to see, that they were done at reputable labs and that they included what we would consider to be the primary breast and ovary cancer risk genes.
I think that's an important point to emphasize, that having access to the source documentation for the genetic testing in the family is really important, because families sometimes misinterpret the results that they've been given. Certainly, patients have the impression there's a mutation in the family and it turns out to be a variant of uncertain significance. I've seen that happen. So when a family says we've had testing and it's negative, it's really important to try to dig deeper and understand what panel, what lab, and exactly what the results were. Zainab, do you want to do any follow-up? Do you know which specific panel this patient's sister and mother had, and did it cover the breast ovary genes that Darcy thought were appropriate given this pedigree?
Yes, Dr. Aron. So both of the patients actually were diagnosed with breast cancer and got treated here at City of Hope, and they got consulted by the genetics department here at City of Hope, and the tests were ordered by them. And so that's, one of them had a panel by Myriad and one of them by Invitae, and both were the broadest panels, which was directed by because our counselors basically go over the different types of panels with BRCA or I'm sorry, breast or ovarian panels versus the all gene panels, and this was chosen by the patients. And so the answer is yes, we do have the genetic results, and they cover all of the ovarian and breast genes.
Okay, and since it was all in-house, you had access to all the results.
Correct.
Let me call on another program. Why don't we go to Beth Israel Deaconess? And the question I'd want to ask is, if this patient was not interested in prophylactic bilateral mastectomy and had these risk estimates that Zainab just provided to us, how would you counsel her for monitoring her in the future, and what alternatives for breast cancer prevention would you discuss with her?
Are we on mute?
You are unmuted, yes. The operator has unmuted your microphone. And please speak directly into your phone so everyone can hear.
And please turn off your computer speakers to prevent any feedback. Hello, can you hear me?
Yes.
Hello?
Yes, go ahead.
Okay. Well, the question was, I'm sorry again, that she did decide to proceed with risk-reducing bilateral mastectomies, and the question is whether or not, how you would proceed with surveillance.
Surveillance, and what would you counsel her? What options does she have for prevention of breast cancer, short of bilateral mastectomies?
Correct. Oh, short of bilateral mastectomies.
Yeah,
well,
if she was not interested in undergoing that surgery.
Right. So if she was not interested in undergoing that surgery, I would put her in the high-risk model and say that she should proceed with MRI, alternating with a mammogram every 6 months, and basically just have enhanced surveillance.
no prevention strategies?
Yes, chemo prevention would be useful, and tamoxifen would reduce her risk by 50%.
So she's 25 years old, I think. Is tamoxifen appropriate in a 25-year-old? Any thoughts along those lines?
It's appropriate, but she would need to be followed closely, and often it's difficult for them to tolerate. So,
I mean, certainly in the breast cancer prevention studies, patients were not enrolled until age 35 or older. So she's pretty young for tamoxifen chemo prevention. If there are any centers there that would use tamoxifen in a 25-year-old, please type into the webinar. I'm very curious if that's something your program is recommending to a woman this age. And probably she's young to consider bilateral salpingo-oophorectomy. We certainly would not recommend that even in a gene carrier at this age due to the risk of premature menopause and the side effects associated with that. So she doesn't have many options for prevention at this age. Susan, do you have any other input?
No, I think that it's, regardless of her genetic status, I think that with all of our patients, it's important to discuss the lifestyle modifications that we know of. Maintaining body weight between BMI of 18.5 and 25, moderate to vigorous exercise every week, which has now been shown from the recent meta-analysis to decrease premenopausal breast cancer also, and decreasing alcohol consumption. So I think that with all patients, we need to discuss those topics.
And before moving on to the next presentation, there are a few questions that were put onto the webinar. One question, Zainab, is whether the patient was asked about family environmental exposure. I guess that's a long shot, but I guess we share genes and we share environment with our family. Was that explored in this patient?
So actually, it does not. We did talk about that. It does not explain all of her history, but they were the mother and the sisters were all, have spent their childhood and for the mother adulthood in the Santa Susana area in California, which is sort of in the valley here, more on the west side. And there are some, reports of increased cancer risk within families. Families with a bunch of different cancers, thyroid cancer, breast cancer. However, it was never actually, well studied and shown as an increased risk. And obviously, it doesn't explain the cancer in her grandmother and her great aunt.
Okay. Thank you for that. I think we should move on to the second presentation, which is Dr. Lerner Askan from Cedars-Sinai.
Can everyone hear me?
Yes, sounds good.
So I'm presenting a patient with a right breast mass. She's 38 years old, Ashkenazi Jewish female. She has a known BRCA1 mutation with a strong family history of ovarian cancer. She undergoes a mammogram in September of last year, which was noted to be normal with a BI-RADS of 1. 2 days following her mammogram, she notices a hard, palpable right breast mass. Before we get more into her current history, in terms of her prior medical history, she only has asthma and depression, no prior surgeries, on home medications that are appropriate for her medical conditions. She drinks 4 drinks a week. She's a non-smoker and has no illicit drug use history. Her family history is significant for Ashkenazi Jewish heritage on the paternal side. Her mother was diagnosed with ovarian cancer at the age of 43, then breast cancer at the age of 62, and she's currently well and alive, and she has a known mutation, pathogenic mutation in BRCA1. Her maternal aunt was diagnosed with ovarian cancer in her late 40s, died in her 50s, and is also a known BRCA1 mutation carrier. Her sister is 36 years old. She's unaffected, and she also has a BRCA1 mutation. In terms of her gynecological history, her menarche was at age 13. She has had no prior pregnancies, and she used birth control pills for over 10 years. Despite knowing her family history as well as the known mutation in her family, she opted not to get tested personally until the age of 38, which was in April of last year, as knowing her mutation status wasn't going to change her management options, and so she waited until she was 38, and she was found to have a deleterious mutation in chromosome 17, similarly positive for BRCA1. Following this, she was referred for surgical and genetics consultation. So after discussion with the GYN oncologist and with us, we talked about the options of prophylactic bilateral mastectomies and bilateral salpingo-oophorectomies. We discussed, if she chose not to undergo bilateral mastectomies, increased surveillance options, but also discussing that the surveillance options for ovarian cancer are limited, and therefore, in significant history of family history, early ovarian cancer, we talked about bilateral salpingo-oophorectomies. The latest at the age of 40 would be generally recommended. Patient desired a future pregnancy and wanted to preserve her fertility as long as possible, and as she believed that her cancer risk was more for ovarian than breast cancer, she deferred prophylactic mastectomies at this time and wanted to proceed with surveillance options. In terms of ovarian cancer screening to date, we discussed undergoing CA-125, pelvic ultrasounds, as well as pelvic exams every 6 months. We did discuss with her that these are not ideal tests with low sensitivities and specificities, but that currently these are the only valid options we had if she chose to proceed and if she chose not to undergo bilateral salpingo-oophorectomies. Her last workup and exam was in June, so about 2 months after she was diagnosed with a mutation, and it was all found to be normal. In terms of a breast cancer screening, we discussed mammograms and MRIs alternating every 6 months, and since she's never had an MRI, we discussed starting off with both imaging studies and then alternating every 6 months thereafter. So we saw her in July with a normal physical exam and ordered a mammogram, which she then proceeded to have in September. It showed extremely dense breast tissue and a BRCA1. A breast MRI was scheduled at that time. And as I had mentioned earlier, 2 days following this mammogram, she palpates a right breast mass. On exam, she was found to have a mobile, vague 1.5 by 2 centimeter mass at 1 o'clock. She had normal skin and nipple areola complex, no nipple discharge, no skin retraction. On the left, she had no palpable masses with an otherwise normal exam. Then both breasts were noted to be overall dense. There was no axillary, supraclavicular, or cervical lymphadenopathy. This is her mammogram that she had performed in September, so 2 days before she had noticed a right breast mass. And again, it shows an extremely dense breast tissue with no suspicious calcifications, distortions, or masses. A right breast ultrasound of the palpable abnormality showed a 2 centimeter hypoechoic solid mass with lobulated borders at 1 o'clock, BRCA4. Ultrasound-guided core needle biopsy was performed, which showed a grade 2 invasive ductal carcinoma, moderately differentiated, and she was found to be triple negative with a high Ki-67 of 50 to 60%. Following the diagnosis, she underwent a breast MRI, which showed, again, very dense breast tissue, and in the right breast, the irregular enhancing mass with spiculated margins at 1 o'clock, measuring 2.3 by 3.2 by 2.5 centimeters. The left breast was noted to be dense but normal with no suspicious enhancement or masses. No lymphadenopathy was noted, and this was categorized at BI-RADS-6. And given her triple-negative breast cancer, we had discussed the options of neoadjuvant chemotherapy, and prior to proceeding with such, we referred her for a fertility specialist, and the options of embryo freezing, oocyte preservation were discussed with the patient. She started hormone therapy to proceed with the oocyte cryopreservation, but was unable to tolerate the treatment, so that was aborted. She then went on to a neoadjuvant chemotherapy and completed 4 cycles of carboplatin and Taxol. She had a moderate response during that treatment cycle and therefore proceeded to undergo adriamycin and Cytoxan. She only tolerated 3 cycles, was unable to finish the 4th cycle, and went on to surgery after. Lupron was discussed with the patient during the chemotherapy treatment, and she declined. Clinically, she had an excellent response to treatment with the right breast mass not being palpable anymore, but on imaging, specifically on ultrasound and MRI, the cancer was still seen. It measured about 2 centimeters on ultrasound, and the MRI showed still a 1.4 centimeter mass with enhancement at 1 o'clock in the right breast. Previously, the cancer had measured around 3.3 centimeters. We took her to the OR April 18 and performed bilateral skin and nipple sparing mastectomies with a right sentinel lymph node biopsy. She was evaluated by plastic surgery preoperatively and decided to undergo immediate reconstruction with tissue expanders. Her pathology showed 2 sentinel lymph nodes that were negative, 1 non-sentinel lymph node that was also negative, and she had residual invasive ductal carcinoma measuring 2.2 centimeter, moderately differentiated. The closest margin was posteriorly and measured 1 millimeter. There were areas of low cellularity noted on pathology, which was consistent with chemotherapy-related changes, but the overall size measured still 2.2 centimeter. The left breast tissue was normal, and she had a staging of post-neoadjuvant treatment of T2N0. Again, the tumor was triple negative, and her Ki-67 had decreased to 3%. So in summary, we have a 39-year-old female, BRCA1 pathogenic mutation carrier with a clinically T2N0 triple negative invasive ductal carcinoma, who underwent a bilateral nipple-sparing mastectomy following neoadjuvant chemo with a residual invasive ductal cancer measuring T2N0. Given her young age, her genetic mutation, and the non-PAT-CR, post-mastectomy radiotherapy was discussed, and patient declined at this point. Additional considerations for this case were the possible trial participation for adjuvant PARP inhibitor therapy, given that she is BRCA positive and had a non-PAT-CR, so she's currently awaiting possible participation in this trial. In terms of her ongoing surveillance for ovarian cancer risk, we discussed referral back to GYN and ONC for continued surveillance and to discuss prophylactic BSO in the near future, as she's currently 39 years old and approaching 40 at the end of the year. But patient is hoping to have a return of a menstrual cycle and a pregnancy over the next year and wishes to postpone BSO as long as she can.
Okay, thank you for that excellent presentation. I think there are several points to discuss. I think one important question to ask is, in this patient who had a known mutation in the family but had not been tested herself until recently, how was she being screened for breast cancer and ovarian cancer?
Yeah, that's a great question. She was referred to us after she tested positive for BRCA1 mutation. Prior to that, she was followed by her gynecologist, mainly for the ovarian cancer screening. In terms of a breast cancer screening, she had 2 mammograms previously, very sporadic and not in a very scheduled setting. No MRIs were performed, and she had yearly exams. Again, she was not worried about a breast cancer at all and therefore didn't take high-risk surveillance options. In terms of ovarian cancer screening, she underwent ultrasound, transpelvic ultrasounds, as well as, transvaginal, as well as pelvic exams and CA-125. But again, it wasn't done at our institution and it was done sporadically.
And I think that this patient illustrates gaps that still exist in knowledge in the primary care field regarding recommendations for enhanced surveillance, even in untested individuals, but if they have a known mutation in the family or a pedigree that is worrisome for a hereditary cancer syndrome, even if the patient doesn't want to undergo testing, and especially if they don't want to undergo prophylactic surgery, making sure they get the appropriate screening is really critical. And how to close that gap, I think, is a challenge. I think it starts with training residents going into primary care to recognize these high-risk individuals before they become affected. I mean, because I think the data would support that screening MRI in addition to annual mammography is more likely to identify a smaller primary than what this patient was diagnosed with. Opportunity for improving education.
Darcy, can you address in this woman with a known genetic mutation in her family, a known BRCA1 mutation, about single-site testing versus panel testing? I believe
Excellent.
she had panel testing.
Yes, that was actually a question that I was going to ask. I guess I'd like to ask the presenter, what type of panel testing did your patient have, and do you know what the thought process was behind why they chose to do a panel in her? Was there perhaps a paternal family history of cancer that wasn't noted?
Yes, that's a good question. We had the same question. The only answers we could come up with was that she had her Ashkenazi Jewish heritage was from the paternal side. Interestingly, there was no cancer history at all on that side, and we're not sure if the mutation on the maternal side was known. So it wasn't done with us. We assume the paternal Ashkenazi Jewish heritage prompted the panel testing. Otherwise, I don't have a good explanation for that. In terms of which multi-gene panel testing was done, it was done by Council. It was a 24-gene testing with a specific gene mutations for hereditary breast and ovarian cancer.
Okay, great. And in indicating that she had multiple family members that tested positive for a BRCA1 mutation, do you know if attempts were made to obtain a copy of any of those results to make sure that we were dealing with the same gene mutation?
No, I'm not sure.
Okay. So with regard to the initial question, site-specific testing versus a panel, in the absence of there being additional cancers on the opposite side of the family that would prompt you to think that there could be a different genetic predisposition, we would typically do site-specific testing in a non-Ashkenazi patient. Since the family history in this case of cancer and of the mutation is coming from the non-Ashkenazi Jewish side of the family, site-specific BRCA1 testing would have been very appropriate in this case, and I would not have done a multi-gene panel unless there was something prompting that from the paternal side of the family outside of just having a Jewish ethnicity. The probability of having a mutation that predisposes you to breast cancer is really not remarkably high. So if we think in terms that maybe 10% of the time we're dealing with a single gene that's predisposing to cancer, That means the vast majority of people who have breast cancer will have it for reasons we can't completely define. So in this situation, I would have done a single-site BRCA test, assuming I could have had my hands on a copy of a family member's result.
Darcy, can you comment on the difference in cost for single-site testing versus a panel?
Sure. So single-site testing is focused, and most laboratories will offer that testing for anything between $200 and $375, depending on what the laboratory is that's used. The patient in this situation had testing done at a laboratory called Council, and Council does provide this 24-gene panel at, a lower cost overall if the patient has to pay out of pocket, but a panel of genes, 24 genes, would probably be on the order of about $2,000 or a little bit more. So certainly the cost in this situation was much higher than it potentially needed to be.
I sent several papers regarding the current hypothesis that there may be a tubal origin to ovarian cancer. And I'm bringing this up because this particular patient sounds like she was very motivated to have children and was highly reluctant to accept risk-reducing salpingo oophorectomy. And currently this concept of salpingectomy followed by delayed oophorectomy is being studied in clinical trials. But I thought it would be an interesting point of discussion and would ask Dr. Ozcan if that is something that was discussed with this patient outside of a trial setting, or if any other programs have been involved with patients where that has been discussed. Dr. Ozcan?
Yes. So we did discuss with a patient that trials are ongoing, or that there is data that suggests that some of the cancers originate in the fallopian tubes, and therefore a salpingectomy with delayed oophorectomy would be an option in her, specifically because she wanted to preserve ovarian function, was concerned about premature menopause. However, with the limited data in high-risk patients, we were reluctant to offer that to her outside of a clinical trial. Additionally, the concern was that she had close family members with ovarian cancer, and we're not sure where they originated from. Doing a salpingectomy at age 38 or even at 40 with her mom being diagnosed at age 43, we didn't believe that would reduce her risk appropriately. We discussed it but did not recommend it.
Can any of the other programs that are online indicate whether they have participated in a similar discussion with a patient, recognizing that it is outside the standard of care? And I agree with this patient with early onset ovarian cancer, it would not be an optimal strategy. I don't see any responses regarding that. Susan, any further comments on this case?
No, I think that the salpingectomy is something that is discussed more and more often. Our gyn-oncs discuss it with the patients, with the younger patients all the time.
Yeah, I guess the last point that I wanted to bring up with this case was thoughts about her risk of local recurrence after a nipple-sparing mastectomy. With a sort of a high-risk tumor, triple negative, early onset, close margin. Is nipple sparing appropriate in this sort of high-risk population? Do you want to address that, Dr. Ozcan?
Sure. We did discuss that there is data that showed that it appears to be safe, and that at the time of the operation we would perform a nipple biopsy, and if on frozen or final pathology there was indication of residual cancer or even in situ disease, we would resect the nipple. But looking at the papers we read and other data, the resection of the nipple is quite low for cancer, and most do not have cancer in them, even if excised for concern for malignancy. So, and with the limited follow-up data, it appears to be safe even in high-risk patients, and therefore we believe that it was a good option for this patient, the size of a breast and the tumor. Additionally, in terms of the close margin, it was a posterior margin and not an anterior margin, so we believe she was safe from that standpoint.
Very good. Okay, we'll move on to the final case, Dr. Sasa Espino from Northwestern.
Hi, good evening. I'm just scrolling through to my presentation. I'm Sasa, I'm from Northwestern. We have a patient, a 34-year-old woman who presented to us back in October of 2016. She detected a right axillary mass and presented to our clinic. Of note, her relevant clinical history is such that she is premenopausal at 34 years old. She had menarche at 17. She's nulliparous, no history of breastfeeding. She's been on oral contraceptives for about 15 years. At that point, had no infertility treatment and no hormone replacement therapy. She otherwise had normal pap and pelvic exams, the last one being in July of that year. Family history is significant only for, actually it's 2 paternal great aunts with breast cancer, one at 45 and the other at 50, but no other cancers in her family, no ovarian cancers, no breast cancers. The unaffected side is mom and dad and 2 sisters, healthy, alive with no cancers. Both paternal and maternal grandparents also alive with no cancers. Diagnostic workup, so she presents to our clinic. Her physical exam is such that we have a palpable 2-centimeter mass in the right axilla. In the upper outer quadrant of the right breast, about 6 centimeters from the nipple, there was a palpable 1-centimeter mass in addition to that right axillary mass. She otherwise had no other skin changes, no other breast masses, and no nipple discharge. She underwent diagnostic imaging, and at 34 years old, she did both mammogram and an ultrasound, as well as an MRI. I'll show you all the pictures and the pathology in a bit, but she also underwent a core needle biopsy of both the right breast mass as well as the right axillary mass. This is just one cut of her mammogram, an LMO view. This was a mammogram in October 2016. As you can see, the breast tissue is heterogeneously dense, and it does obscure small masses, which is what she essentially had in her right breast. In the upper posterior right axillary region, not very well seen right now, there's a site of a palpable abnormality. The clip that you can see here is where the mass is, and you can see some distortion just inferior to that clip. The ultrasound of the breast gives us a little bit better view of the breast mass. Here in the breast, there is a suspicious 1 by 0.8 by 0.6 centimeter irregular mass. It's, like I said, 6 centimeters from the nipple in the 10 o'clock location. It's irregular, it's lobular, it's hypoechoic, and it is, as noticeable, taller rather than wide with indistinct borders. Another picture of the ultrasound of the axilla. This is a thickened cortex with a loss of a hilum, and it looks like it's completely effaced by tumor. It was measured at 2.4 by 2.2 by 1.9 centimeters, and it's most compatible with the morphologically abnormal lymph node. A couple of slices of the MRI, I thought this was pretty impressive. You can see on the right side at the 7 o'clock position, there is a large conglomerate of lymph nodes, both in the level 1 and 2 axillary lymph nodes. The largest lymph node was measured at 2.6 centimeters, in the right axilla. There were additional lymph nodes totaling about 6 in estimate that were abnormal looking. On the next cut of the MRI, that's just another area where there's enhancement from the 2-centimeter mass in the right breast. You can see that there's malignancy contained around the coil clip, as enhancement around the coil clip as well. Her pathology after core needle biopsy was performed on the breast and the axillary masses. It showed a triple negative, right breast invasive ductal cancer grade 3 in both the right breast as well as the right axilla. And the lymph node actually was almost, the one lymph node that was biopsied demonstrated a lymph node that was almost completely replaced by cancer, with the largest metastatic focus being 1 centimeter. And as I mentioned, it's triple negative with a high Ki-67. This is a sample of her breast core needle biopsy. It's her infiltrating ductal cancer. You can picture the atypical tumor cells from the tubules penetrating the basement membranes of the duct and infiltrating the surrounding tissue. There is also infiltration into the lymphatics and perineural space in this particular picture. This is her lymph node metastasis. On the top right is actually the normal part of the lymph node. That's, I think, the only part of the cores that were normal. Everything else looked like the bottom left, which is essentially tumor infiltrating the entire lymph node. Because she was so young at diagnosis, she did meet with genetic counseling, and she was panel tested. She was tested for BRCA1, 2, APC-ATM, BARD1, MSH, PMS, and PALB2. She was found to be negative for everything else, but she was found to have a mutation in the PALB2 gene. We mentioned a VUS earlier, doesn't really provide too much information, but she does have a VUS and the MSH2 gene as well. In terms of her care, because she was a triple negative with a biopsy-proven axillary lymph node metastasis, our decision was for her to undergo neoadjuvant chemotherapy. And again, she is very much interested in having children in the future, and so she met with reproductive endocrinology. She underwent oocyte cryopreservation. Just like the last patient, she was offered Lupron during neoadjuvant, but she declined at the time. She did undergo neoadjuvant chemotherapy, ACT, and tolerated it well. And then our plan was to undergo surgery and adjuvant radiation. On the day of surgery, she underwent bilateral nipple-sparing mastectomies. We localized one of the large biopsy-proven axillary lymph node on the right axilla and proceeded with a dual mapping sentinel lymph node of the right axilla, so blue dye as well as technetium injection. She underwent bilateral tissue expander immediate reconstruction at the time. What's great for this patient is that her final surgical pathology was there was complete pathologic response to the chemotherapy. She had no residual cancer in the right breast. We took out actually 10 lymph nodes on the right axilla. No residual tumor was found, including the one that was wire localized. We did a subareolar biopsy on both breasts, even though the left breast had no cancer, no known cancer, and everything was benign. Her adjuvant treatment, she met with radiation oncology, and I think the plan for them is to proceed with adjuvant radiation, and she's going to undergo physical therapy. And so that is where she is right now. She is recuperating. This was about 2 weeks ago that she underwent surgery. She's recuperating before starting radiation.
Okay, very interesting case, and I would like to start by asking Darcy to comment on how she would approach a 34-year-old with a new diagnosis of triple-negative breast cancer, but kind of remote family history of breast cancer, 2 great aunts, but no closer relatives. What testing would you advise for a patient like this?
So in this situation, if I were able, I would probably have offered her a breast-specific panel that would include the high and moderate risk genes. Because they're actionable and because it would reduce the possibility of getting a variant that ones are insignificant, particularly since we have a number of close family members who have no history of cancer, and at this point her grandparents are likely to be at least in their 70s. It looks like she had probably a more pan-cancer panel, the MyRisk panel at Myriad, or the breast ovary panel at Myriad, which also include the Lynch genes, evidenced by the MSH2VUS. So I probably would have offered her, if possible, a site-specific breast panel, BRCA, P53, P10, ATM, CDH1, CHEK2, and I think that's it.
PALB2 would not have been included in that panel?
No, PALB2 would have been included in that panel, so it would have been an 18 panel. Yeah. And so interestingly, her family history is pretty devoid of cancer, which sort of leaves us with that conundrum of, risk had she not had bilateral mastectomy, of what her risk would be for her contralateral breast. And then furthermore, what the risks are to family members who potentially carry this gene mutation. So in the article from Dr. Couch, he shows a 7-fold increase in risk with PALB2 mutations, and that was supported in sort of the initial paper that came out in 2014, looking at a number of families that have PALB2 mutations. But that first article suggested that the penetrance of the breast cancer risk may be higher with multiple closer family members. So I think this is just sort of showing us that we still have a lot to learn, and that unfortunately the majority of the studies that we're doing to look at these genes are in the clinical setting where we're looking at a biased population, and that these people are undergoing testing for reasons, either personal diagnoses or family histories. So I think we're going to continue to be learning a lot.
I think any mutation that's found in a patient with a diagnosis of breast cancer, it's easy to jump to the assumption that it's a hereditary cancer. But what do we know about the phenotype of breast cancers that develop in PALB2 mutation carriers? Sasha, do you have any idea?
Well, so for breast cancer specifically, it has a significant increase in the risk of breast cancer. In terms of pancreatic cancer and male breast cancer, as well as ovarian cancer, there's no proven data. There's no definitive data in terms of how high the other risks are. In the papers that I've read, including the 2014 PALB2 paper, it shows that your risk as a PALB2 carrier, your risk for breast cancer as a PALB2 carrier increases if you have a history of breast cancer in your family. I think much like the same for other genetic mutations. But I think it's very interesting that she had no other family history as well.
I agree, that's very interesting, which leads to the question, and maybe I'll try to get another program to comment on this. Knowing she has a PALB2 mutation but does not have a significant family history of breast cancer, would anyone offer her breast conservation, and what are the issues in offering mutation carrier breast conservation? Why don't we go to Washington University, if we can unmute their microphone. Is Washington University on the phone? Okay, why don't we go to, is Yale participating? Can we unmute their microphone?
We do have Washington University unmuted now.
Oh, okay, thank you very much.
Hello?
Hello, is this Jennifer?
Okay.
Hi, Washington.
Yes. Yes. So in regards to the fact that this cancer may potentially not be actually directly correlated with her PALB2 mutation, you could consider offering her a lumpectomy. However, I feel like in general, with patients with that are so young when they get breast cancer, usually both our physicians along with the patients prefer to undergo prophylactic mastectomies and treatment mastectomies, partly just because of the burden of following up with MRIs and mammograms, knowing that they have the mutation as well.
I think that the uncertainty makes it a challenge in knowing what their risk is. With a PALB2 mutation, how would you counsel her? What would her risk of local recurrence be with breast conserving therapy? And then what would her contralateral breast cancer risk be?
In her specific case, again, it's a little bit hard to say with the fact that her family doesn't have a lot of other people with cancer in it. In regards to the specifics, I'm not sure exactly what I'd quote for percentages.
I think you're struggling, and it's very reasonable to be struggling because I don't think we have good data to help us counsel this patient about local recurrence risk or contralateral breast cancer risk, because we're just beginning to understand the breast cancer risk associated with PALB2, and it is so tied to the family history. And whenever there's uncertainty, it's very hard to counsel a patient. Why don't we rephrase the question? I'm sorry, Susan?
No, I was just going to follow up on that and say, go back to Yale, is when you have a situation like this where we don't have data, how do you counsel a patient? And what do you tell them? If we can unmute Yale.
Hello?
Hello, is this Yale?
Yes.
Go ahead.
Sure. So in a patient with a PALB2 mutation, again, in this case, we're not, I would not be able to quote them a specific percentage. I would tell them that we know that this is a high-risk penetrance gene, and there are associations with breast cancer. Regarding breast conservation specifically, I would tell them that we don't have specific data on that. We hope to in the future, but unfortunately right now we don't. And I would best educate her and extrapolate, knowing that with high penetrance genes like BRCA, we do know there is a much higher risk of ipsilateral breast recurrence and contralateral breast primaries as well. And I would help her make that decision based on that information.
So let's take this to this discussion to a BRCA patient. You're seeing a BRCA positive patient, similar age, triple negative breast cancer, who strongly desires breast conserving therapy. There are a few papers looking at the risk of ipsilateral recurrence and contralateral risk. What would you advise her, and how would you monitor her if she elected breast conservation?
Sure. So for a 34-year-old patient who's BRCA positive, I would explain that breast conservation is an option. The only problem is the risk of recurrence is about 4 times greater than for a patient who's not BRCA positive. I would tell her if that's what she chooses, we would again follow her with MRIs and stagger that with mammograms every 6 months alternating. If she was over the age of 60, then I think I would explain again that the risk of recurrence is still extremely high, but that given her age, that she's an older woman, and also take into consideration other comorbidities, I think it's a slightly more reasonable to do breast conservation if she chooses so.
I mean, based on the papers that were in the reading, is the risk of local recurrence extremely high, as you say? Is that consistently reported in the literature?
The one I remember reading specifically was, I think they said 4% per year.
Yeah, but it seems to also be affected by receipt of chemotherapy or not. And in patients who receive chemotherapy, the local recurrence risk is not as high as patients who do not receive chemotherapy. And whether it's recurrence or a new primary, I think, is also a question. But these are all critical discussions to have with these patients so they can make an informed decision. What about risk of radiation in known genetic mutation carriers? Is there a risk of radiation-induced malignancy?
Yeah, for certain mutations, I think there is. I know ATM would be one that I would not want to have to give radiation to in a postoperative setting, and I believe CHEK2 is the other that you do not want to give radiation to in the postoperative setting as well.
And I think the paper showed that for at least BRCA carriers, because that's really the only group of hereditary cancer patients where there's reasonable data, the acute and long-term side effects do not seem to be worse in BRCA mutation carriers. There's a lot less known about radiation and some of the other mutations. So let's go on to, how about Rutgers? What would you recommend to this patient for screening for other cancers moving forward?
Is Rutgers unmuted?
They're unmuting right now. You are now unmuted.
Is Rutgers?
Go right ahead.
Okay, maybe they're not available. I mean, if you have not had a chance to look at the NCCN guidelines for hereditary cancers, there's a very nice chart at the end of the guidelines that beautifully outlines the cancers associated with some of these genes that we're now testing for routinely, and what screening and surveillance is recommended for those patients. And I would strongly encourage everybody to refer to the NCCN guidelines for management of these patients to know what the appropriate follow-up is. Darcy, do you have any further comments either about this case or the previous cases?
Actually, I do have a comment about this case. So although NCCN is a wonderful resource, there are other resources that make recommendations with regard to screening. And the American College of Gastroenterology provided a practice guideline in 2015 that suggested that because of the fact that PALB2 gene mutations are overrepresented in familial pancreatic cancer families, they do support surveillance in mutation carriers who have first or second degree relatives with pancreatic cancer, recognizing that this is a conditional recommendation and there's limited evidence. But in our practice, if we have a patient that has a first or second degree family member with pancreatic cancer and they have a PALB mutation, we do refer them for consultation to discuss endoscopic ultrasound. Typically that would be done about 10 years prior to the age at diagnosis of their affected family member. And then the other aspect that I think is important to raise in this case is that this PALB2 is also associated with Fanconi anemia, and if a patient and their partner both carry a pathogenic variant in the PALB2 mutation, there is a 25% chance to have a child with Fanconi anemia. And so I think it's worthwhile for these younger patients who may wish to have children to at least discuss that as a possibility, recognizing that the frequency of PALB2 mutations in the population is unlikely to be high, and that the probability that an unrelated partner would also carry a PALB2 mutation is low, is still worthy of discussion in the event that partners wish to be tested.
Thank you for those points. And any final comments on the current state of genetic testing and where you see it going in the future?
I see it becoming more and more complicated. I think that we are going to have to be careful in how we manage these patients, because we're going to find more and more less penetrant genes that in the past we would have not identified, and we would have been labeling the families as having a familial predisposition, which, as you noted earlier, Dr. Arndt, is really sort of due to a combination of multiple factors, both genetic and environmental. And I think that we're going to need to become more sophisticated in our ways of assessing and calculating risk, because we'll need to take additional factors into account aside from just a specific mutation.
Yeah, I think as we offer testing to more and more individuals and their families and more data is collected, it will perhaps make it more complicated, but it may also offer a little more clarity in that we may discover that some genes that we thought were high risk may not be as high risk. I mean, an example of that is in the Couch paper. In the population that was examined, genes like the neurofibromatosis gene and NBN were really found to not be associated with a higher breast cancer risk. And that's different from even what NCCN has in their guidelines now. So I think for all of us, genetic testing is a moving target, and keeping on top of the latest updates and which genes we really need, which genes are actionable and change how we manage a patient. We need to keep those separate from ones for which we need more data. Susan, any other comments?
No, I mean, I think that the points that were made are excellent. I think it really is incredibly important that as surgeons we are knowledgeable about genetics. We're frequently the first line, and if the patients get past us and we don't refer them to genetic counselors or we don't test them, the patients frequently get missed. The other question that I have for Darcy, and being respectful of the late hour, is, in general, I mean, genetic testing and panel testing and all of this has changed so much over the time, as have the guidelines. How should we, or what patients should we look at retesting? I mean, years ago there were no guidelines for triple negative patients. Now it's triple negative under 60. You know, how aware of these changing rules? And if you look back at patients that were tested in 2001 or early 2000s, they didn't even have BART testing. So how do we approach these issues?
Sure, that's an excellent point that I do make when I talk to various professional groups. And I think that if you have a patient that's returning annually to see you, it may be worthwhile, if they were tested quite some time ago, to just say, you know, you may want to make contact with your genetics provider to talk about updated testing. Prior to, I believe, 2011, BART testing was not ubiquitous. It was only offered regularly to patients that met a specific criteria that Myriad had. So really, if you had a patient that was tested prior to 2011, it may be worthwhile to send that patient back to consider updated testing, if for nothing, just to make sure that they have comprehensive BRCA testing done. And I suspect that most of their providers would offer them the opportunity to look at a panel as well. But certainly the patients that you have that have striking family histories, like our first case, who underwent testing some time ago, it may be worthwhile for them to be repeated. In our correspondence to our patients, we suggest that they contact us periodically to see if there's anything new that they should consider, and certainly to contact us if they have any changes in their family history, since that is a dynamic aspect.
Okay, with that, those final comments, if there are any last-minute questions from any of the participating sites, please type them into the Q&A section of the online portal. But I do not see any additional questions at this time, so I'd like to thank everybody for participating. I hope you found this to be informative and educational, and we will send out information about future webinars.
Thank you all for participating. Thank you, Darcy, our special guest. Thank you.
Thank you for inviting me.
Thanks.
Good night, everybody.
Good night. Bye.
Ladies and gentlemen, this concludes today's Society of Surgical Oncology webinar. Thank you all for attending.
The moderator has ended the